Hello everyone, and welcome to this special webinar for members of the California Association for Licensed Professional Clinical Counselors. My name is Sarah Kremer, and I'm the Marketing and Communications Chair as well as President for CALPCC, often referred to as CALPIC. Unlike some of our other webinars offered to assist counselors in understanding more about the new license and applying for the LPCC, this presentation has been recorded without audio participation. We listened to you, our members, about your need to know more about insurance reimbursement, and we contacted an expert who will be sharing her knowledge with us through this recorded webinar. Should you have questions after listening to the entire webinar presentation, you'll find information about whom to contact at the end. Today, our expert presenter is Barbara Griswold. Barbara is a licensed marriage and family therapist in private practice in San Jose, California, and the author of Navigating the Insurance Maze, the Therapist's Complete Guide to Working with Insurance and Whether You Should. She has over 19 years experience as a provider for more than 20 insurance networks. She publishes a monthly e-newsletter about insurance issues, which I actually subscribe to and I find it's very, very helpful. Provides phone consultations to counselors nationwide with insurance questions and problems, and travels around California teaching counselors about the ins and outs of working with insurance. With that, we'd like to welcome Barbara, and I'm going to turn the webinar over to her so she can share her presentation. Thank you, Barbara.
Well, thank you, Sarah, and thanks for that plug. That was very nice for my newsletter. So obviously this is a topic, first of all, welcome to all of you, and it's an honor to speak to all of you. This is not a topic that most of us are really excited about spending time learning about. There's lots of fun other topics that we'd rather learn about. However, it's a topic that, in my mind, is really, really necessary. It's one we mostly did not get a lot of time in graduate school. Most of us didn't get much time from our supervisors or about how to kind of keep our businesses open and how to work with insurance. So the practical business side of keeping your door open and getting clients is a topic that I have a lot of passion about. So let's talk about why should we learn about insurance. In tight financial times, obviously, clients are having more need for counselors who accept insurance. In the old days when I started out, pretty much everyone had private paid. Their insurance didn't cover counseling. They may not have any kind of mental health coverage. Now more and more clients do have mental health coverage, and they're looking for counselors who do accept their insurance. Also, more and more counselors are now telling me, hey, I have open slots in my practice. I used to have a lot of people who could afford to pay out of their pockets for therapy, and now, they don't have that kind of extra income. They're needing to use their insurance. Tight financial times means that sometimes counselors are now rethinking their stance on not taking insurance. So you may be in that situation also. In addition, with the Affordable Care Act, also known as health care reform, also known as Obamacare coming, we're going to have 33 million more Americans who will have insurance by 2014. That's a lot of people, which also means that hopefully insurance plans are going to be recruiting more therapists and counselors to their ranks to serve these previously uninsured Americans. So we have more Americans who have insurance, who are going to want to use that insurance to seek counseling, and more, hopefully, counselors who will be on the ranks of insurance providers. The other thing is, even if you say, what, I don't want to join plans and I'm just going to have a private pay clientele, I'm not going to deal with insurance, very frequently your clients are going to say, I want to seek reimbursement for the money that I am spending on your services. And what you don't know can hurt your clients. So I think it's a very dangerous supposition that some of us have, which is, I don't need to know about insurance. I'll just let my client deal with insurance plans. That's not something I need to know about, because it really can come back to bite you, and it can come back to bite your clients in very major ways. So having some basic knowledge of how insurance works and can give you some ways to help them that you didn't know about before, and some ways to make sure that they get the care that they need to advocate for them. Also, LTCCs are now accepted by most major plans. CALPCC has put together is in the process of putting together a spreadsheet they've been working on for the last 6 months or so at the time of this recording, and they're putting it together, and they're going to be posting it on the website of which of the insurance plans are saying that they accept LPCCs. And, when I kind of glanced through that, it looked like most major, I started to make a list of the ones that, and I was going to print it here, but there were so many that accepted LPCCs that right now it's really a great time to be joining plans because they do accept this license. So that's a great time to learn about insurance. So today we're just going to quickly follow a case example to kind of help us out here. Your new client is Cinderella. Cinderella has come to you after marrying the prince. Turns out that relationship's not going quite as storybook as she might have hoped it was going to. She's having kind of an adjustment disorder. She's now having to dress for dinner. She's having to learn the palace rules. Everything is quite different for her. Sit at the end of that long dining table, just her and the prince. They don't speak much. Kind of different than cleaning all day. So anyway, turns out the mice at the palace say, why don't you go ahead and maybe talk to somebody, maybe that would help you. So she may have some kind of insurance that covers that. So what kind of insurance might she have? Let's talk about some terms first that will help us understand what kind of insurance she has. She will probably have some kind of a managed care insurance plan. What does managed care actually mean? That means that her insurance plan puts some kind of limits on the coverage that she has, the fees that the doctors can and the therapists can set, the number of sessions she might be able to have. There's usually in every insurance plan of these days, and this is kind of new actually in the last 20 years, there's some kind of limit that has been set on coverage, fees, sessions, etc. So that's what we kind of use managed care interchangeably with the word insurance because pretty much all insurance plans are managed care plans. Deductibles. What's a deductible? That is the amount that Cinderella might have to pay out of her pocket before her insurance kicks in. Now, do all plans have a deductible? No, not all plans do, but most do. So it's a very important thing to say when a client comes in and says, don't worry, I just have a $10 copayment. Well, she may have an $8,000 deductible. That means she needs to pay the first $8,000 before insurance pays dime one. And high deductible plans are more and more common these days. So it's a very, very important construct for you to know and for you to check out before your client starts telling you what their coverage is and you believe it, and there's more pieces of the puzzle. And we'll talk a little bit more about that down the line. Co-payments and co-insurance. Co-payments and co-insurance, not quite the same thing, but co-payments basically is what flat fee a client might have to pay when they come to your session. And a co-insurance might be the plan has a percentage. So let's look at that again. Maybe that Cinderella comes to see you and her plan says that she has to pay a $10 copayment every time she comes to see you. It's a flat fee. It's the same every time. Or her plan might say she has a 10% co-insurance and she's going to pay 10% of the agreed upon rate that you have with her insurance plan if you're a plan provider. Let's say her plan is Blue Cross. So we'll just use them as an example. And she may pay 10% of every time she goes to see a Blue Cross provider. And if your agreed upon rate with Blue Cross is $65, then she pays $6.50 every time she sees you. Okay, could be that low, really. Okay, and I want to explain network and panel. I'll be using those words interchangeably also. There are network providers and panel providers, same thing, same difference. Basically, Anthem Blue Cross goes out into the world and says, hey, providers, we want to have you in our network, we want to have you in our panel, or you apply to become a network or panel provider, same thing. So use those words interchangeably. And they contract with a certain number of people to have on their network and to provide services to their members, and we'll talk about what exactly that means. Okay, so what kind of plan might Cinderella have? She might have an employee assistance program. This is something that many employers offer, not all of them, and it would pay a certain number of free sessions for Cinderella and each family member to see a network counselor. It's usually not more than 3 or 4, sometimes it's up to 8 sessions, but it's intended to just be an assessment, short-term therapy, and referral if needed. Why would the employers offer this? Because they have found with research that if people can go in for a certain number of free sessions. They tend to have higher workplace attendance rates, higher employee satisfaction, nip problems in the bud like alcohol issues, etc. So it's something that they have found statistically that it behooves them to do. Now, pre-authorization may be required for the, I don't want to say maybe, it's typically required for these sessions. You can't just walk into an EAP session. You have to find a network counselor, and you need to get pre-authorization from the EAP plan. And this is typically in addition to health coverage. People don't typically just have an EAP program. I've seen some people who do, but they typically also have some kind of health coverage through their work site. Now, let's say Cinderella uses her EAP program sessions, and she says, wow, I kind of like this therapy thing. I'd like to continue in my basic mental health benefits through my medical plan. And she looks up and she says, well, what kind of benefits do I have? It's going to depend what kind of plan she has. So I've named here just a couple of the most common kinds of plans that are out there. She may have an HMO or an EPO plan. This is a health maintenance organization. Less common is an exclusive provider organization. I've lumped those together because the thing you need to know about them today, since this is kind of just a brief overview, is that these plans only will cover plan providers. So if she has an Anthem HMO plan and you're not an Anthem provider, the thing for you to know is that you're not going to be covered by her plan. Okay? And it's something you can explain to her. It's something you should just know. Or if she has an EPO plan, it's the same deal. Now, the typical, we think of Kaiser having an HMO model, but that's usually ones that are, on-staff model. But that's not the only kind of HMO. That's kind of a historical HMO model. But it's also a community model where Anthem, again, contracts with people in the community just to provide their HMO services to their HMO members. There's nothing different about the counseling that is provided. It's just who's covered. Now, again, this may require pre-authorization, which means the client would have to go to or call the insurance plan and get authorization to start with you. Sometimes they ask the therapist to do that. But now, the other kind of plan that's kind of even more frequent out there these days is a PPO plan, or less likely a POS plan. This is a preferred provider organization or appointed service plan. And I lump those together because the most important thing you need to know about that is two things. Number one, Cinderella has her choice of seeing any provider, but she's going to have a two-tier plan, sometimes a three-tier plan. She's just going to pay more if she goes outside of network. So she can see any provider she wants, but if she sees a network provider, she's going to pay less. And if she goes out of network, she's going to pay more. Now, in California, a California plan must pay for any licensed provider. They don't have to pay for interns. They don't have to pay for other folks. But as long as it's a licensed person and it's a California health plan operating in California, and you want to just double check this, they have to pay for it even as an out-of-network provider as part of the PPO plan. Now, so Cinderella may say, I've heard such good things about you. Even though you're out of my network, I really want to see you. Super. So if she knows that she has a PPO plan, it's something that she may go ahead and do because she knows she's going to get reimbursement, perhaps, for some of the whatever she's paid out of pocket to see you. Now, something that you need to know, though, however, is she might say, well, look, I get 50% coverage for out-of-network folks. So she might have, let's say, 80% coverage if she sees someone, a therapist or counselor who's in network. She may have 50% coverage for someone who's out of network, and she may think, that's okay. Your fee is $200, let's say. I'll submit this to my insurance plan, and they'll pay me $100 back. That's maybe not going to happen, because what I want to just kind of point out here is that plans may cap their reimbursement for out-of-network providers. They may say, we have what we think is a UCR, or usual, customary, and reasonable fee. We may think $200 is too much for anybody to charge for that service. So we may cap it at $100. We may say that's the maximum, and we're going to pay 50% of that. So they may only reimburse Cinderella $50. I hope that makes sense. If not, call me afterwards. But basically, I just want you to kind of know that they may not just accept whatever fee you charge and pay half of that. So this can be an important concept to talk to clients about if they're really needing reimbursement from the insurance plan, and they're relying on that. You may want them to look into this concept. Now, what choices do you have? You can become a network provider. What are the key elements of becoming a network provider for, let's say, in this case, Anthem Blue Cross? You join the panel, and what does that mean? That means you sign a contract, and a contract that you may not be able to read all of because it's a lot of legalese. But the main thing that they're going to ask you is that well, we'll get to that in a second. The good thing about signing a contract, we all know this, hopefully you'll be getting referrals from the plan. That's the ideal thing. And when people from the plan call you, you can say, yes, I accept that insurance plan. Yay. The con, of course, is that you are agreeing to submit the claims for the client. You can't say, oh, you have Anthem Blue Cross? Yes, I'm a provider, but you need to submit the claims yourself. No, no, no. You are agreeing by becoming an Anthem provider that one of the incentives clients have for choosing you is that you are now going to take over the burden of submitting claims directly to Anthem for them. The other thing you are agreeing to, the two big things, is that you are going to accept a discounted rate. And this could be as low as $60, it could be $50, it could be $65, $70. It really depends on everyone asks me what's the rate that you have to accept. It will depend on the plan. It will depend on your licensure. It will depend on your location. It will depend if you've tried to negotiate something higher because you have some kind of specialization. But typically it will be some kind of, discounted rate. Now, some people say, well, I don't want to do that. I just want to be an out-of-network provider. How do I go about becoming an out-of-network provider? What do I have to sign? Well, people don't really understand that any counselor who didn't sign a contract with Anthem Blue Cross is automatically an out-of-network provider. So you don't have to do anything to become an out-of-network provider. You're just automatically an out-of-network provider for any insurance plan that you did not sign a contract with. And I want to say really kind of quickly here, keep really track of who you've signed contracts with. I have a lot of therapists who later come to me and say, I didn't remember signing a contract with this plan, and later a member came to me and I didn't, I collected full fee and it turned out I was on the plan and blah, 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 blah. So it may sound strange that you wouldn't remember signing a contract, but it does happen. So keep track. Now, what's the good things about being an out-of-network provider? What does that actually mean? You can collect your full fee from any client who walks in the door because you didn't sign a contract. Or you can collect a full fee from an Anthem client, let's say, because you're not on that panel. And you don't have to do any kind of direct billing. You can just give an invoice, also known as a super bill, also known, what else do we call it? Invoice, super bill. There's a third one I'm not coming up with it right now. So you can give an invoice to the client for the reimbursement, and they can just submit it on their own. So it's certainly less burden on your point. You're not accepting a discount. You certainly are able to slide your fee if you want to, but again, you don't have to accept a discounted rate or submit the claims. Downside, of course, is that you typically are not going to get plan referrals. The plan is not going to be posting your name on their website as a plan provider. They're not going to be giving your name out. Also, clients obviously prefer a network counselor because they're going to get a discount when they see somebody on the network. And many plans don't pay out-of-network counselors, as we said earlier. So HMO and EPO plans only will reimburse for in-network counselors. So those people particularly are going to want to seek somebody who's on their plan typically. So you may be saying, well, if I want to, how do I get invited to the ball? How do I become a network provider? Joining networks can be difficult right now. And a lot of people come to me and say, I don't even try because I hear that they're all full. Well, it's kind of like my 19-year-old daughter came to me and said there's no summer jobs out there. Yeah, what she's saying is it's really hard, but I say there's no such thing. I do help people. I coach people how to get on insurance networks, how to kind of market yourself, which is something that we therapists aren't particularly good at as a whole, I have to say. And we think that we can just fill out an application and we're going to get on panels or we just shouldn't bother. And I'd say, don't think about that. There's no such thing. Every day I coach people to get on managed care panels, and even the full ones are, some of these people surprisingly will get an application and will get on the panel, and I'm not always sure why. Again, you just keep putting yourself out there. You don't overthink it in terms of what are they thinking, will they accept me. You just do the best job you can at marketing and selling yourself. And what I encourage people to do is develop what I call a managed care resume. Basically, you put together something that's not the same as a normal resume. Probably most of us have a resume, academic resume, experiential resume, but it's not going to be one that is absolutely targeted to managed care. It's not going to have the buzzwords that managed care insurance plans are looking for. It's probably maybe even have some things on there that will hurt you in an application. If you're talking about your psychodynamic background or training, some of the more esoteric stuff that you may have done or be doing, they may not see you in the light that they're looking for. So, I help people develop a managed care resume and a cover letter and help them figure out what is it that makes them stand out from all the other therapists that are in their building or in their area. Especially if you come from an area where there's a lot of other therapists, this can be very difficult. And if you're kind of what you would call a garden variety therapist, you got to kind of figure out what is it that you have that makes you stand out, what training. We'll be talking a little bit more about what they're looking for in a minute. And what I encourage you to do is once you kind of get your little sales pitch documents, get a list of plans, and then send your resume and cover letter to these plans. And I know a place where you can get a list of like 60 plans, and just do a blanket mailing, basically, and ask for an application and see who bites. You may start with some smaller plans and get on those and start working with them, and maybe later you apply for, or get some applications for bigger ones. This is going to take some patience, but I think it can be a really worthwhile thing. So where do you get a list of the plans? One is, as we said, the CALPCC is coming out with an insurance plan list of who accepts LPCCs, and that spreadsheet hopefully will be posted soon on the website, and hopefully they'll have contact information there. I've also listed another place that you can get a list of, I believe she has about 60 plans, and this is a therapist named Fran Whitner, and that's her website. If you click on Practice Products, she has not only a list, you can also even get mailing labels where you can just go ahead and get the different plans already in mailing label form and all set for your resume and cover letter. So what are they looking for? Typically, I'll say they are looking for you to be licensed for 2 or more years. Some want 3 years. But go ahead and apply even if you aren't. I know many people who have gotten on plans even if they aren't, because they have some kind of special experience, special language skills in our location that is not well served. It could be all kinds of things. Again, don't spend too much time in their head. Just sell yourself. And all they can do is come back and say no. Apply again when you have more years of licensure. But great, so good. Location is huge. Those of us, again, who live in very urban areas where there's a lot of therapists, or as many therapists as Starbucks, that can be one of the major stumbling blocks. But again, go ahead and apply. If you have a second office, that can be a helpful thing if it's in a less underserved area. But sometimes they do feel like two offices that are reasonably farther apart may give them kind of like 2 for the price of 1. In that you can cover more members in different locations. So that's something I would kind of sell to them. Hey, I've got an office in San Francisco and also one in San Jose, so that way, I get to cover more of your members. That's kind of how I might phrase that. If you have any language skills, sign language fluency, that's often something they're looking for. Be sure that this is something that's fairly fluent, though. We're not talking about, being able to order a taco. This needs to be something that you can do in a session fluently. They're looking for cognitive behavioral. I mean, that's a huge thing. Symptom reduction focus. These are some of the buzzwords that they want to see on that managed care resume. And I do help people put together this resume so that you can have these kind of buzzwords. Symptom reduction focused, problem solving, that's what they're looking for. Now, a lot of people are like, I don't have cognitive behavioral. Yeah, probably you do. Probably you just don't use those words, but most of us work with people's thoughts and behaviors and how those two things go together. And probably if you read up a little bit on it, it probably is something that most of us do. Now, brief orientation, we'll talk a little bit more about this later, but certainly that is something they're looking for. If you're somebody who sees clients 3 times a week, you probably aren't going to fit into a managed care orientation. They typically want you to see clients typically once a week at the maximum. And they also want people that have a sense of pushing people through therapy, reducing their symptoms, not technically eliminating all of them. So I put on here, most cases they would like to see you done in 25 sessions. Now what they would like and what's reality, I don't know that most of my cases are done in 25 sessions. I haven't gone back and counted, but I'm just kind of putting that up there that I saw that from one plan said that. So it's just something to kind of keep in mind, is they do want a sense from you that that is something that you are comfortable with. You do have somewhat of a brief orientation. They're interested in people who have addiction, substance abuse, eating disorder, background training, and that's very important to highlight. If diversity, cross-cultural issues, if you have a high background working with cross-cultural and diverse clients, I'd highlight that. Also, if you are of a different culture, they need to have a very diverse membership on their therapist panel, so that's important. Even men can sometimes, I think, get on a panel easier than women because they may sometimes need more men than women because there's more women on the panels. Immigration can be a field that they're looking for now, but a particularly hot one now is veterans issues. If you work with veterans or their families, PTSD because of all the returning veterans, trauma, chronic pain. These are some very hot issues right now that they're looking for providers. And providers who work with children, especially if you work with autistic, ADHD kids, if you can provide ABA work with autism, that's something that they're looking for. If you can do wellness lectures or critical incident debriefings, this is something that a lot of employee assistance programs look for people who are able to come into an employer site and give a lecture or give a critical incident debriefing when there's been some kind of a robbery or a suicide or whatever. And EAPs may want certification or experience. It's sometimes hard to get on an EAP panel. Sometimes they want you to have taken some courses and gotten a certification in becoming an EAP provider, or they may want you to have several years of experience as an EAP provider, which is all paradoxical because how do you get in the door? So I just encourage people to start out with, see if you can get on an EAP that doesn't require these things, get a little bit of experience, and then go ahead and reapply to some of the EAPs that have those requirements that you have 2 years experience as an EAP. Hopefully that makes sense. So myth or reality? Some people say, well, one of the reasons I don't accept insurance is that way my treatment can't be reviewed by the insurance plan. I want to say that's a myth. People think, I don't accept insurance. So the insurance is not going to review my plan. I want to just say this very clearly. If your client turns around and at any time submits an invoice to their insurance plan, as soon as they do that, they're basically saying, I am okaying that my treatment can be reviewed by the plan for whether it's medically necessary treatment or whether this is something that is going to be payable, what exactly occurred. So it's just something I wanted to put out here on this slide to just kind of remind everybody that as soon as your client turns in that invoice, your notes, the plan can request to review your care, to read your notes, and so that's just something to kind of keep in mind and to be able to tell a client who might be concerned about confidentiality or to want to know what their rights are. Now, if I accept insurance, a lot of people are concerned my case will be micromanaged by idiots. Well, I'm going to break that into two parts. Number one, will your case be micromanaged? As Sarah said at the beginning, I've been doing this for 19 years. And I think people would be surprised. Most of my cases are insurance cases, and I don't feel micromanaged. You'd probably be surprised at how little even contact I have with the insurance plans that I deal with on a daily basis. I mean, I submit lots of claims to them every month, and I really don't feel micromanaged at all. I probably get a call once a year from a plan, and it's on a very complex case. So they tend to manage the cases that are very complex, that you're seeing probably a lot more than they would think you should for the diagnosis. And once I talk to them, they kind of understand what's going on. They say okay, they check their boxes, and they go away. And I don't feel micromanaged by the plans. That's not something that I have experienced. And the second part of that is micromanaged by idiots. Starting out, again, 19 years ago, we would sometimes have clerks reviewing our care, and that was sometimes difficult for those of us with licenses. Now, most of the people that I will talk to at an insurance plan, in fact, all of them will be licensed professionals, and typically somebody with, a master's level license, and at least, if not more. And so it's just something to keep in mind that, my experience is not that my cases are micromanaged, and when I am discussing a case, I am discussing it with someone who I consider a peer. If I accept insurance, I must deal with HIPAA. This is also a big concern for a lot of people. They're like, oh, I don't want to deal with HIPAA. I'm not going to spend any time with what HIPAA is, and if you don't know what it is, please, I encourage everyone to go take a little short course in it, read something about it, read some articles. I just want to say here now that there are absolutely ways that you do not have to deal with HIPAA, and you can bill insurance. I have a therapist across the hall. She does all her billing by mail and doesn't deal at all with the internet. HIPAA is basically if you do electronic billing by the internet, if you share any of your client's private information to the third-party insurance plan by the internet, if you check their coverage via the internet, then you're going to have to deal with HIPAA. And, I don't find HIPAA to be really a lot of work, and most people who I talk to don't find it much of a big deal. But if it's something you want to get around, let me just say you can certainly get around it. So don't feel like that's something that should keep you from working with insurance. Couples therapy isn't covered if I accept insurance. People are concerned about that. This is, again, something that I find to be mostly a myth. All the plans I work with, and again, I work with over 20 different plans, they all cover couples therapy. Now, if I called them up and I said, do you cover couples therapy, they might say no, which is kind of funny to me. If you call them up and you say, I have a client and he has a covered diagnosis, and I'd like to bring in his wife and I'd like to do therapy with the CPT code for couples therapy, 90847. Is that covered? They will say yes. So you may have to learn to ask the question in the correct way by giving the CPT code, which we'll talk a little bit more about later, which is the kind of service code. So as long as, when you just call up and say, is couples therapy covered, they tend to think you're just doing like couples counseling for communication issues, and they may not find that that's something that they want to cover for under medical insurance. We'll be talking about medical necessity. But if you say somebody in the room has a diagnosis and I would like to do couples counseling as to treat that diagnosis, it's a different ball of wax here. So don't worry about being couples therapy. I do couples therapy all the time and get covered by insurance plans. And you can do couples therapy even when they're doing individual therapy, and insurance plan will cover both. I am restricted to brief therapy. So as we said before, they do have a brief. They do want you to do brief therapy, but they can't restrict you to brief therapy anymore. Why is that? In 2010, came out with a federal parity law. Some of us knew about parity before that. I'm not going to talk too much about that. I want to go right to what's the latest on parity. As of 2010, in most plans and for all diagnoses, mental health and substance abuse coverage must equal a client's medical coverage. What does this mean? In the old days, a client used to have 20 sessions a year, or they would have 10 sessions a year. There were all kinds of limitations. But with this new federal parity law, since most clients have unlimited sessions with their doctors, and since this parity law said, hey, whatever their medical coverage is needs to be the same as their mental health, now almost all of my clients have unlimited sessions to see me. This is pretty cool. This is a really big historic thing that happened in 2010. So right now, if I were to call every one of my clients' insurance plans, almost all of them would say that they have unlimited sessions based on medical necessity. And that's why I put in red there, if the plan feels they're medically necessary. And we're going to talk very briefly later about what that exactly means. So that's the caveat. That's the catch. But for most of your clients, they're going to have unlimited sessions, which is great. So you don't have to do brief counseling with your clients. Now, there are some exceptions to the parity law. Small employers, if they have less than 50 employees, if it's an individual plan, that means a non-group plan, some self-funded plans. In those plans, coverage may have some limits depending on diagnosis, which we won't talk a lot about here. Again, if you want to find out more about medical necessity or parity, on my website, which I'll have at the end, there are some articles about both medical necessity and parity, so you can find out more. But let's spend a moment talking about what is medical necessity. I don't want to spend too long, but it's such an important concept. I want to make sure everybody understands it because it's coming up right now. Despite parity, plans can refuse to cover sessions that they don't think are medically necessary. So this is the big loophole they've found. Okay, suddenly the plans were like, oh my God, what? Everybody can have unlimited sessions with our members? We don't like that. That's going to be really expensive. So this is the big loophole that they found, is that they still have the right to refuse to cover sessions that they don't see as medically necessary. Well, this is true even for out-of-network providers. I really want to stress that. So don't think, oh, that doesn't apply to me if you're an out-of-network provider. Just keep submitting those invoices. Even at some point, they can say, you know what, we've covered an awful lot for this client. We want to find out more about whether your treatment is medically necessary, and they can review your treatment. So just a few things to keep in mind. Again, I'm not going to go a long time about medical necessity here. There's more on my website. But when you're talking to the plans about your treatment, a few things you need to know about what is medical necessity. That means that there's some kind of DSM illness present or suspected. Okay, the person can't just be coming because they like you and you're such a nice lady and you're so interesting. There has to be some kind of DSM illness. Remember, this is medical insurance. Okay, they must feel that this is the most appropriate level of care. They must feel like it's the most cost-effective level of care. In fact, sometimes they may feel like a higher level of care, like an inpatient treatment, would actually be more cost-effective. Instead of seeing you once a week, maybe somebody who has an alcohol problem should be in some kind of more intensive treatment, or someone who has a more serious personality disorder, they may feel would benefit more from some kind of intensive treatment. The client must be participating and improving. So, you know, if you kind of overkill talking to them about how your client is doing so poorly, if there's no improvement, they may say, you know, why should we keep paying for sessions if the client's not even following your instructions or isn't really improving? Why should we keep paying for sessions? On the other hand, if they're too sick, obviously they may say, well, maybe we should put them in more intensive treatment. So you have to find that sweet spot. And it kind of helps you think about why exactly is this the best treatment for your client? So as we said earlier, it has to be necessary, not just for personal growth. This is really important. A lot of our clients do come to see us for personal growth. And an argument could be made that this isn't something that should be billed to insurance plans, because insurance will say, that's nice, I'm glad that they like personal growth, but this is medical insurance, and we only cover medical symptoms. And if there's no medical symptoms, that's not something we should be covering. So something to just keep in mind when you're talking to the plans is that you should not be talking about self-esteem, personal growth, feeling awareness, that you're helping them get in touch with their feelings, their childhood issues and how they were abandoned or how they had attachment problems. Again, you can see that these are not current symptoms. These are not current. If you talk about communication, you're helping the husband and wife with communication. You need to be thinking this is medical insurance. Think of yourself as a doctor and what symptoms currently, anxiety, insomnia, depression, what kind of impairment is going on currently that you are trying to help them with. And again, articles on my website can help you learn more about this. So let's talk about starting treatment with Cinderella. How does she find you? Typically, she's going to go these days to the Anthem Blue Cross website, and she's going to type in her zip code, and up is going to pop a whole bunch of names, perhaps with the kind of specialty. She may even be able to type in the specialty she's looking for. And there's going to pop up a whole bunch of names. What's the next thing that's typically going to happen? She's going to start Googling those names one by one by one by one. And that's why I said the next little point there, websites, why you still need a good one. Because if she Googles your name and you're not there, she's going to go on to the next name. It's like a blind date, right? So she's going to go to the one who has the wise, kind eyes and the nice picture and the discussion about the approach and, with the nice wording that's so welcoming and talks about fees and times and all that good stuff. So I really just want to plug here in terms of the marketing thing. You still need a good website, and or else you're going to not get those referrals. Now, obviously, the only way that Cinderella finds you is not websites. Some of them will call Anthem Blue Cross and say, can you refer me to someone in your area? So sometimes that'll be in my area. Sometimes that'll be how Cinderella will find you. Or she may have just heard about you from a friend or whatever and calls you and says, do you accept my insurance, whatever. One of the first things you're going to want to find out is whether she needs pre-authorization for the treatment. And don't trust her. Always, call and find out. And that's the next thing I say. Why you should call the plan before the first visit, even if she already has. Very often clients will tell us, hey, I've already called my insurance, I've already checked, or hey, I just saw a therapist, I already know my coverage. Don't just ignore everything that a client tells you about their insurance. That's my rule number one. And number two, ignore most of what their card says about their insurance. Don't assume anything has any validity. I say not making this call is a huge mistake. I consult with therapists all the time who have lost all kinds of money because they didn't make this call up front. And I would say 99% of them, if they had made this simple phone call before they started treatment, they would not have lost hundreds and hundreds of dollars. So sometimes, they find out later that they aren't covered, that this client had a huge deductible, that there was some, and this client's already gone out of treatment and they can't get the money, and there's all kinds of issues that come up later that if they had just made the call up front, they would have known. So how to get her to agree. What I typically say on the phone after I've, connected with the client and hopefully talked to her and we're kind of gabbing and make the appointment, I say, hey, what I would like to do is to call your insurance and just make sure that I get all the information from you and make sure that you are completely covered and we don't have any problems down the line. How would you feel about that? And typically, when you present it as, I don't want you to have any trouble down the line, they're not going to say, oh, no, I'd prefer to have trouble down the line. They're typically fine. They're like, sure. And I ask her to go grab her card and give me the information off the card, which would include her date of birth, the policy number, group number. That's usually the most important things, and who the subscriber is, whether it's her husband, who's the primary member on the card, and the phone number of where it might say mental health coverage or just at least a provider's call or even customer service is fine. Now, definitely I try to make that call before they come in, because sometimes you're going to find out some bad news that might alter whether or not she's going to come in or be able to pay for your services. If she finds out she has a $6,000 deductible, for example, she may say, well, I can't afford to pay out of pocket to see you. I thought I had a $10 copayment that I could afford. So again, she may say, I can't afford to come see you, and you help her refer to someone in the community. So ask for the information from her card, but again, don't trust the information on it. It may be the medical plan information. Very often what's printed on her card is actually medical plan information, not mental health, especially like the address. So don't trust it. Also, it may be what we call a carve-out, and that's where the mental health coverage is provided by another plan, even though it doesn't say that anywhere on the card. A good example of that is currently in California, Blue Shield of California. For most of Blue Shield, they will have carved out their mental health coverage to Magellan Behavioral Health. Why does this matter to you? Well, the card says nowhere on it Magellan. It says Blue Shield. Maybe you're a Blue Shield provider, and you say, oh, guess what, Cinderella? Yeah, I'm a Blue Shield provider, no problem, blah, blah, blah. But it turns out that if her mental health coverage is managed by Magellan and you're not a Magellan provider, you may not be covered at all. And this can be true for Aetna, it could be true for Cigna. It can say nowhere on the card that it's carved out. So you need to make that phone call and find out ahead of time. Very, very important. And you're going to need to ask more questions that are on the card. What do you need to ask? Well, here's some of the questions. In my book, I have a worksheet that you could copy of, but here are some of the questions off that worksheet. You want to know what the copay and coinsurance are. So you're going to call the insurance plan and get these questions are questions you want to ask the insurance plan. You want to ask the deductible and the amount used this year. So maybe she has a $6,000 deductible, but maybe she had surgery early this year and she used it all up, so maybe that doesn't matter. Or maybe it's 0, and that is going to be a big factor for her. The claims address for mental health claims. Again, the one on the list on the card may not be the correct one for mental health claims. Whether she needs pre-authorization. If so, when? Sometimes they need pre-authorization after the 10th session or after the 12th session, or they may need it right up front, or they're not going to cover anything. Is it a calendar year plan? Here's a funny question. A lot of plans start January 1st, most of them, but some start July 1st. And so their deductible may start over in the middle of the year. So that's a question you need to know. Do they have any yearly session limits? Does coverage vary depending on diagnosis? And that would be if it's not covered by a parity, the federal parity law is basically what you're trying to find out there. Am I a network provider for this plan? So again, make sure that you didn't sign a contract, because sometimes the carve-outs are just very confusing and don't say anywhere. And don't let Cinderella get away. How you can keep her even if you're not on her plan? Let's say she calls and she says, are you a Anthem Blue Cross provider? And you say, no, I'm not. What's the next thing you're usually going to hear is a dial tone, right? So we don't want that to happen. We want you to, one possibility, and I find this works really well, is that you chat with her and say, I'm so sorry, it must be really hard to find somebody out there. You try to build some rapport and say, how about if I would like to call your insurance plan for you and see what kind of coverage you might have for my services. It may be that you have a PPO plan or POS plan, and they would at some level cover your services or my services. How about that? Would you be willing to have me call your plan? And usually they're like, sure, that would be awesome. So get them to give you the information on the phone. Give a call. If they have a PPO plan or a POS plan, find that out and say, hey, it turns out, you've used up your deductible for the year maybe, and maybe the news is that you have a 60% coverage for out-of-network. So, here's how much you would have to pay when you came in versus, you would pay my full fee when you came in, but it looks like you would get a reimbursement of about this much. Now, sometimes at that point, they'll say, gee, I don't know if I can afford that. Or they'll say, well, I think I could afford that. That's possibly doable. If I'm going to get some reimbursement from the plan, I could do that. That feels good. And other times they may go away and say, thanks for checking into it. I really appreciate that, but I don't know if I can afford that. And then maybe 4 weeks later, you'll hear back from them, and they'll say, you know what, I tried several other places, and I haven't been able to find somebody, and you were so nice to check into it for me, and I really appreciated that. And I'm just really needing to see somebody, and I liked that you went the extra mile for me, and you were so nice to talk to, and I'd like to make an appointment. So a lot of what we need to keep working on is kind of building that good faith. Going the extra mile sometimes does, bring back to you some clients who you would lose. Another thing you can do is to offer courtesy billing. You can say, I am not on Anthem Blue Cross, but if you pay me in full when you come in, I would be happy to send the bill in for you. This can be a big seller for some people who are depressed, who are highly anxious about dealing with insurance plans, who've had problems in the past, and it doesn't really bind you in any way to do anything but submit the bill, which is not that difficult for those of us who do it. And there may be if you've never done it before, there may be a little bit of just learning curve, but it's just you sticking it in the into an envelope pretty much and submitting it for them. That can be one way that you even advertise on your website that you will do some billing for out-of-network as an out-of-network provider. It might make you stand apart from your colleagues. Another thing you could do is single case agreements. This is one that has been very popular with a lot of people who've come to my workshops, and a lot of the counselors have said this really has worked for them. If someone's coming to you and said, I really want to see you, I've heard you're a specialist in sexual addiction, let's say, and I haven't been able to find anyone on my panel, on the Anthem Blue Cross panel, who's a specialist in sexual addiction, who could see me, who has availability, would you be willing to do a single case agreement? Now, clients don't usually know about this, but if you know about it, it's something you could potentially bring up. What it means is that she could contact Anthem and say, look, I found somebody who's outside the panel. I haven't been able to find anyone on the panel, and I need someone who specializes in this area. And basically, Anthem's not providing that. And they really need to provide somebody who for a reasonable specialty. So if you might be willing to contract with Anthem, with what a single case agreement means, is for this one case, you're going to act kind of like a preferred provider, like a plan provider. You're going to sign a contract to submit the billing for this one client, and you're going to agree on a fee. Now, the fee doesn't have to be their usual fee for plan providers. You can talk, because you're an expert here and you're saying, hey, I'm serving a specialty situation, you can often get your full fee, or you can somehow negotiate something in between. But that's something that you might suggest to a client who's calling you and they've called around, they can't find something. You might suggest to them that they go back to the plan and say that you would be open to a single case agreement, and the plan will typically call you and try to arrange that. Another thing to know about is a transition of care agreement, which is when your client, let's say you're seeing them and you're on Cigna plan and they're seeing you, and then they change over to Anthem Blue Cross and you're not on Anthem Blue Cross. Sometimes you can contact the new insurance plan and they will pay for a certain number of TOC sessions, which they call transition of care agreement, where they agree to pay for a certain number of sessions while you transition this client over to someone theoretically on their plan. You don't have to. You could just finish treatment. They could just start paying them out of pocket, but sometimes the new plan will pay for a certain number of sessions. Just something to know about. So these are different ways that you can try to keep that client from going away, and I think it's important to think about. Now, a few talks about, we're not going to spend a lot of time in all the ins and outs of getting paid. That could be a whole other webinar, and maybe we'll have to do that sometime. But here, I just want to kind of introduce you to, this is what the form looks like. If you're a network provider, most plans are going to use this form, which is called the CMS 1500. It used to be called the HCFA 1500 or HCFA 1500, and still gets called that a lot. So just to let you know, that's what it looks like. If you're an out-of-network provider, you don't typically use this plan. I mean, it's the form, you certainly can, but typically you give them a receipt, an invoice, super bill. Those are all words that are used interchangeably. And then they attach it to something that looks like this that's given to them from the plan and send it into their plan. So what isn't magic? I'm going to just talk about some common denial areas since, again, we could spend several hours talking about filling out this form. But common denial areas that all of us should be aware of typically involve missing or wrong information. So one of the interesting areas is incomplete diagnosis. First of all, you should have a diagnosis. If you want insurance to pay for it, there needs to be a diagnosis on your super bill, on your claim form, whatever kind of, it needs to have a diagnosis on it. It needs to be very clear. And you need to use the full number of digits. Every diagnosis has either 3 digits, 4 digits, 5 digits. Very annoying. I wish they all had 3 digits or 4 digits or 5 digits, like, consistently, but no, some have 3 digits, some have 4 digits, some have 5. And if you don't use the full number, they sometimes will kick back the claim to you. So if you put down for major depressive disorder 296.3, they may kick that back and say, well, you didn't put the 5th digit, which tells how severe it is or whatever. Okay. Now keep in mind that the DSM-5 has just come out, and you know, my caution is, as I record this webinar, it's in June of 2013, and you know, I'm waiting for the insurance plans to say when we should be using that. I don't know when is the big answer to that. Even though there is a new DSM-5, I don't encourage people to start using that right away. So ask the plans which codes they're using. It probably won't be till next year or at the end of this year that they're all going to be on board. So be sure you have the full number of digits, get a list of all the diagnoses from the DSM, and make sure each one you've gone to the full number of specificity is what they call that. The wrong place of service code, there's a place for place of service code, which is where did you provide this service. And sometimes people write the word office or OV or off. You need the code, which is 11, and that specifies office. Now, if you did it in a hospital, if you did the service in a home, there are other codes. So just Google place of service code, and you should be able to print out a free list and pick out where you provided the service. Wrong CPT code. This sometimes will be a problem for you. The CPT code specifies the type of service that was provided. Now, the new codes, a whole brand new set of codes, went into effect as of January 2013, and some people are still using the old codes, and that's causing lots and lots of problems. So make sure that you're using the latest set of codes as of January 2013, that you're using them appropriately. On my website, there is a special report on these codes that is available, and if I can answer questions about that, you're certainly welcome to contact me. But make sure that you have the CPT code on your invoice or on your claim form and that it's correct. Late filing is also a big issue. Need to be sure that you remember to file a claim for, if you're in network, they may reject your claim if you haven't, if you don't submit it within 60 to 90 days of the session. So get on top of that. Stay on top of your billing. Out-of-network people, don't forget to put your tax ID number on your invoice, okay? And you may even need to send, and I would do this personally, a signed IRS W-9 form with your first claim. If you've never worked with that plan before and you're out of network, they just need something that you sign that says, yes, that's my tax ID number. I am actually that person, whatever. I'm not sure all the reasons they need it, but I have had personally them reject claims for my daughter when they did not have an IRS W-9 form, and I had to get the provider to send one in, and it delayed the payment of the claims, and really annoying. So I would have a provider send one in with the first invoice, so something that you can just have available. I want to talk very briefly about the NPI, which is the National Provider Identifier. This is part of HIPAA. It's a good idea for everyone to get, I just want to say. You have to have it if you are a HIPAA-covered entity. If you do anything electronically of sharing your client's personal identification information, you definitely have to become a HIPAA entity, and you then have to get a National Provider Identifier. However, I think everyone should get one. It's going to make your paperwork easier, and the plans are asking for it even on the phone when you call. And I've given you the website where to get it. It does not replace your tax ID number. I want to make that very clear, too. And there's two types of tax ID numbers. There's your Social Security number or your employer ID number. but the MPI doesn't replace it. It's just one provider identifier that you'll be using with all your plans to say, this is who I am. This is a common number that all the plans can use to identify me. Another little tidbit I want to put here is I encourage everyone to get an employer ID number, which can replace the Social Security number. You don't want to be putting your Social Security number, well, most of us don't, on our claims, on our invoices, and giving those to clients, having those floating out there. It helps protect you from identity theft. So this is just a number that all of us can get. If you have a private practice, just go ahead and get an employer ID number, and it can replace your Social Security number on claims. And I've given you the website for that. So, beyond princesses, why do I accept insurance? You know, insurance is a big pain in the neck. I'm not going to tell you it's not. It takes a lot of time. It takes a lot of energy. I do spend a lot of time on the phone. But some of the reasons that I do it is that our full fee is out of the reach for so many of my clients. The clients I work with sometimes have, many of them have trouble paying their $10 copayment each week, and that's a big deal. These are people who would never be able to afford regular therapy or even weekly therapy without this kind of support up there in this financing that insurance provides them. I also find that it gives me a richer variety of clients. I'm not just seeing the the richer elite folks. I can see people of all walks of life, all socioeconomic backgrounds, diversity that I wouldn't normally be able to see if it was just private pay. And clients pay high premiums for their insurance plans, yet one study of counselors showed that only 49% of them accepted insurance. So there seems something a little bit backwards to that we pay these great high premiums. We want them to turn around and be able to sign people on our plans, and yet so many of us are choosing not to be available to insurance to the insurance members, which is understandable completely typically because of the low reimbursement rates for us. The good thing is that clients may continue privately once insurance ends, and they refer private pay clients. I see that a lot. A lot of my clients have referred other clients. And my practice is self-sustaining. I would say probably each day I get 2 calls for new clients, and they're all referred by insurance. So I have a reduced need to market myself. Plans help market me. Fills all my empty slots. I just don't have empty slots because I do have so many insurance plans referring to me and so many insurance clients who are referring their friends and colleagues. So that's the good side. If you're not an outgoing person who loves to do a lot of marketing, insurance can really help you with that. So, therapy, basically my biggest reason for doing it is that it makes my therapy, my work that I do, more accessible for the less affluent. And I want my practice to kind of look like this final slide here, kind of more diverse for students. I see single moms. I see all kinds of families. And that little picture of the woman way over there on the right there, that's me when I was 29 and I first went to counseling. I was a graduate student. I had so little money. I was living on ramen noodles and in a 3rd floor walk-up apartment, and graduate student that was losing like 150 pounds. I was so stressed out. And the only thing that made it possible for me to go to counseling at that time was my husband's health insurance. And I felt like that changed my life, the ability to see a counselor at that time. And I'm so grateful to the insurance that allowed me to change my life, that I do hope that I'm able to provide that opportunity for others in accepting their insurance. So if I can help you help others to find their ways into your practice and make your work more affordable to others, I want to really put myself out there. Here are contact information for me, and you're certainly welcome to email me with questions, just simple one-shot questions, or for schedule consultations. Also at my website, there's all kinds of resources. Please spend time looking at it. You're certainly welcome to, of course, purchase my manual, insurance manual, which goes Any questions you would have is in there about working with insurance, line by line, how to fill out forms and claim forms. My special report on the 2013 CPT codes. You can buy claim forms there. You can read articles of all the topics we were talking about before. And you can sign up for my free monthly email newsletter, which goes out regularly. So I also wanted to tell you about the American Counseling Association. Has a lot of very important, helpful post discussions about insurance and private practice. And I think Sarah is going to tell you some of the things that CALPCC has to offer in terms of resources. And with that, I'm going to turn it over to Sarah, and thank you all for coming. And if there's any way I can be supportive of you and your practice, please contact me. I'd be happy to do so. Sarah, you there?
I'm here. Great. Thank you so much, Barbara. That was incredibly helpful. We know there was a lot of information covered in the presentation, so we'll be able to post a copy of these slides again in the members-only section of our website where you're viewing this recorded webinar, so you can look through them at your own pace. So once again, you can contact Barbara Griswold, our expert presenter, for more information, or you can look to the CALPCC website to find more information through the members-only online forums and information about regional networking events. And I did want to mention, I know Barbara did mention the referred to the insurance spreadsheet. That's something that the board of CalPIC has been working on since 2012. It may be posted by the time you view this webinar, and if not, it will be up soon. So please be patient with us as we complete that. We wanted to give our members, a leg up, something to start with, and that way we've gone through and tried to contact a number of insurance companies and get that crucial information that Barbara's been talking about so that you're ready to go there. So again, thank you so much to Barbara for this expert presentation, and also a big thank you to our members. We look forward to providing you more information through future webinars and other communications. And with that, that's the end of our webinar.